Now, normally I speak too quickly, so I'm going to slow down a bit. Okay. I am unclear as to the level to pitch this. So for some it'll be too high, for most of you it'll be way too low. Okay? So forgive me, I'm going to try and give you a synopsis of neuropathic pain and CRPS. You might be able to spot the difference. Normal, abnormal. We'll talk about what those changes are and why they matter. There are a lot of sorts of pain, but let's get our definitions out of the way. I'm going to step to and fro. I'm really sorry for being on this side. Neuropathic pain is a pain that comes, or change in sensation, or from the dysfunction of the nervous system. Okay? It's not the same as what you might consider normal or nociceptive pain. Chronic regional pain syndrome is a pain management emergency. Now that's a bit of an oxymoron, okay? But bear with us. It's that is probably the most important take home. If you see it, you send it straight away. We tell our physios, we tell our orthopedic surgeons, we tell our neurologists, we tell our rheumatologists, send it, don't dwell. You will be seen within 2 weeks if you have even a flicker of CRPS. Okay. We all kind of know there are different sorts of pain. There's a difference between a toothache and sciatica. There's a difference between sunburn and appendicitis. Nociceptive pain is your medical phrase for normal pain, your twisted ankle, your sprained knee. Pain is coming from the periphery. Okay? So, osteoarthritis, most especially for hip and knee, is almost entirely nociceptive. And there's a great proof behind this. You take away the nociceptive area, the hip and knee joint, and the vast majority of patients, not all we know, but the vast majority of patients have a reduction in their pain. It's not perfect, nothing is, but many get improvement. You try the same operation in the spine, for back pain, they will get worse. They're different sorts of pain. Sciatica is a classic neuropathic pain. Okay? That's my scan 3 days before I started as a consultant here. And you might see the L5S1 disc as completely obliterated spinal canal. I don't recommend it, though when I went in the scanner with a leg that I could barely move, that felt like somebody had set fire to it, I thought to myself, please God, let it be a single disc. It's a single disc. Visceral pain is a more complex disorder of the organs. Now, pelvic pain is a classic visceral pain. Irritable bowel syndrome is a classic visceral pain. Normal bowel function that gives you pain. I appreciate there are other symptoms, but that's within. Back pain, as always, is the great mystery in pain management. Okay? At least we now know it is not a nociceptive pain. If you have back pain for more than about 6 weeks, you will have an irreversible change of your nervous system. Stick your brain through an MRI, it has changed. If you have symptoms for more than a year or 2, it will never go away. And 80% of 80-year-olds have chronic daily spinal pain. It is a consequence of standing upright. It is normal in some cultures. In Nepal, the Nepalese report almost no back pain. Eastern Europeans, 21%. Different backs, just the same. It's a cultural problem. And we're going to talk about CRPS. We won't, sorry Galton, we're not going to go too deeply into fibromyalgia, which we know is a complex behavioural as well as neuropathic disorder. But it's a can of worms so big it's probably a barrel. That's for you to remind yourself. It's a lesion of the nervous system. There are quite a few types of neuropathic pain. Jerry will see quite a few neuralgias. I see a lot of sciaticas, Trauma. Somebody operates on you, paper cut right through to rip some of your back out, put 45 different screws in your spine. You will end up with pain afterwards. If you're unfortunate enough, you'll get neuropathic pain both acutely in hospital and afterwards. Cancer. There is a different disorder now happening that didn't happen when I started training. So survivor pain. You give somebody platinums, it'll ruin their small nerves. It is almost, I won't say intractable, but very, very challenging to treat. So these are developing disorders. And the rare ones, you have a huge stroke, will present with pain down one side of the body. Question back already, hello.
We're struggling to hear because of the air conditioning.
Talk to the people with the air conditioning.
Okay.
You know he's off, thank you. Shall I project some more?
Yes.
Okay. Neuralgia. Rare, but terrible, facial pain. A pain from multiple sclerosis. This is the one that we see. This is good news, ladies and gentlemen. Okay, bread and butter for many people in the audience, you and me both. Somebody has sciatica, smile. The vast majority will get better, irrespective of what you do. Okay? The natural history is it gets better. However, it is so debilitating, you can crank up the physical therapies, the manipulative therapies, the medical therapies, the interventional therapies, or like I had, a decompression. It's the one to have. I continue to get daily neuropathic pain and numbness in my right S1 nerve distribution. So if you want a description of neuropathic pain, it is dysesthesia, allodynia, hyperalgesia, every single day. Am I walking around Tunbridge High Street with a pair of crutches and dark glasses on? No. How the pain affects you as a person is every bit as important as the condition you have. So some will thrive with these conditions and others won't. Doesn't make them bad people. It's just that's the way of human being. Diagnosing neuropathic pain. This is the formal way. I'm going to give you a cheats guide in a minute. Okay? The Leeds assessment score is what you should be doing. I should be doing. But in truth, you can ask patients a couple of questions and do 3 things in clinic, which is almost pathological. You can describe the pain, describe the distribution, find out the history. Find the area that's sore. Okay. Ask them to describe it. If it's spontaneous, episodic, shooting, stabbing, burning, that's neuropathic pain. If it's provoked, it's not quite the same, but provoke it with non-painful stimulus. Always use your little finger, it's slightly less threatening. If you use your little finger and it's painful, that's allodynia. That's neuropathic pain. Okay. If you want to test mechanical hyperalgesia, apologise, pinch them. If you pinch the good side first, then pinch the other side, you'll get a comparison straight away. If they respond to that, it is neuropathic pain. Now you can get out your needles and your feathers if you wish, but I don't. Because the treatment is not going to be advanced. But ask and just test little fingers. Deep breath, everyone. It's the science bit. Okay? This is unclear. Almost certainly, it starts in the periphery, i.e. the nervous system that's not your brain and spinal cord, and sensitizes the center. That's the best, simplest way to think about it. Now we can go into our molecular model. We can go right up to your spinal cord. We go right into the aqueductal brain, or the medulla, but we shouldn't really do that. If you have long-term neurological sensation in the periphery, 6 weeks or more, it will sensitize the center. And here's the other thing that neuropathic pain will do. It will decrease your central pain inhibition. Decrease the inhibition. Every single day, your body is turning pain on and off, on and off. In a moment, almost all of you will shuffle and shuffle across your legs, across your legs. Okay? Because the sensations are slowly building up from the heels or the arm, and they will, at one point, you'll say, that's a bit sore, we'll move. You won't know you're doing it. When you have neuropathic pain, your ability to turn down that, which we call endorphins, though they aren't the whole picture, the ability of the body to do that is reduced. So you can turn down your pain less well. So it's not just an afferent problem, but an efferent problem. Okay? It's not what goes in, it's how you deal with it. That's all about music.
So sorry, Richard. I'm just going to try and turn this phone about touch. So I think what's happening is we're losing you a little bit at the back of the phone.
If it's helpful, there are 5 seats here.
Do you not have a mic?
Fran, are there any mics? Prepare to swelter, everyone. People at the back, do you want me to go through that again? I know it's the sciencey bit. Do you want to speak about that briefly again? Any nods or any shakes? There's one nod. Any more nods on that? Okay. Sensitize the periphery. Sorry, the periphery sensitizes the center. Okay, it's your brain mostly. Okay. But it also turns down your body's ability to reduce pain. Which is what I said at the end. So now you're getting increased response to peripheral stimulation. So if you rub your arm with your little finger, what is normally non-painful now becomes painful. That's neuropathic pain. Is it like sunburn? Not, but it's a nice enough analogy to think, why is that now painful? Treatments are disappointing for neuropathic pain. Something that's only been really understood for the last 10, 20 years, are bound to be disappointing. Physical methods work for everybody. Please get moving. Okay, go and see a specialist, get moving. Perfectly sensible. Helped me a great deal. You can remove nerve compression, but as David Bell, one of the spinal neurosurgeons, saying, we don't know if you decompress a nerve in the spine, what truly happens. We don't know how quickly we should decompress that nerve. We used to say straight away, but we don't know. We used to say if you have paresis, weakness, we have to decompress it. That's not entirely true. It has to be functional paresis, with the patient willing to accept the risks of an operation, low in the back, significant in your neck, compared to the likely merits of doing so. And these days the spinal neurosurgeons will not promise anything. Okay. Nor should you. Okay. Recently, a successful point of law added to the consent guidance document from Montgomery in 2015, which successfully criticised the spinal surgeon in the court for over-egging the pudding, for saying that the outcomes from this surgery would be better than they truly were. There was no complication, there was no negligence, but their back pain, which he said would be better than 50-50 chance, got worse after spinal surgery for sciatica. Leg pain got better, back pain got worse. We see that, of course we do, but successfully sued. Your patients need to know the truth. Terrifying, isn't it? We're talking about mostly pharmacology. Psychological treatments in this part of the world are flawed. Okay, we do not have enough. Hastings used to have an overwhelmed psychology service. Good luck getting pain psychology unless you're in London or Medway. It's historical. There's not a lot we can do about it at the moment. I've asked every year for 9.5 years. Nothing changes. This is what spinal surgery will do for you. Okay? At 1 month, blue is go home, see a physio, it'll be fine. Okay? This is 2 years. When did you last see an orthopaedic follow-up? 2 years. What about you? Pretty good. If you leave it alone, things get better, but they don't go away. If you leave sciatica alone, single level disc prolapse. If you leave it alone, the leg pain gets better, but it doesn't go away. Your back pain does the same. These are surgery compared to nothing. So this paper meant surgeons no longer leap in and operate. You're right to say, but there's a difference, isn't there? Yeah. And you can think of steroid as a short-term version halfway between the two. So what we do these days is say, you'll get an injection in your back if the physical or pharmacological treatments don't help. And if that doesn't help you and you have a concordant lesion in your back, meaning on a nerve, please consider surgery. Now clearly it's patient dependent. If you're a footballer, you might get it done in 10 minutes. If you're a lady in a wheelchair, you may not get it at all. The point there is, surgery doesn't come at the start, it comes nearer the end of the process. And you can't get an operation at King's for sciatica without an injection. Non-drug options. Okay. Localized neuropathic pain, a burn, a scar that now feels like it's on fire, patch of post-herpetic neuralgia will respond to lignin. Whether you can make it last a long time is another matter. Capsaicin delivered either as a cream or as a patch is okay. You've all had a chili. Any of you had a chili every morning for breakfast for a year? No. Okay, but if you do, it will not be as hot at the end of the year as it is at the start. Welcome to desensitization. Burning the nerves that have neuropathic pain within them is poorly evidenced and last resort. So if you have a trapped nerve in your spine that is decompressed and is still giving you neuropathic pain, it is a quandary that pain medicine has yet to work out. If I burn that nerve, will I make things better or worse? Evidence is unclear. Try to leave it alone, actually. This is what you need to know, ladies and gentlemen. These are your batting order for antineuropathics. We get our docs to prescribe this if they could be bothered to ask the question, have you got glaucoma or a conductive heart defect? Pretty much the only two things you have to worry about. But they are much the most effective group. But if you give your patients over, Neil has a view on 50, 55, 60, 65 amitriptyline, they won't like it. They'll sleep better, but they'll sleep during the day and not wake up. Gabapentinoids. First line GABA, pre-GABA. There is no difference truly about it. There's a slight difference in availability. Patients love the fact you don't have to take a lunchtime dose of pregabalin, therefore the compliance is better. You recognise that this works centrally, and you recognise this is an antidepressant as well. And if you think about your neurological system, there's no true difference between trying to address the nervous system on the skin or in your brainstem. It's all part of the same continuum, which is how I tell my patients, you need an antidepressant. I don't say you need, you might want to try an antidepressant for this. Opioids are rapidly becoming less palatable. This country has had a stronghold, from the pain clinics anyway, of how they are toxic. In this area anyway, I can't vouch for others. They are probably more toxic than we think in the long run. And as we say, morphine is morphine is morphine. There is really no great difference between pethidine, codeine, tramadol, OxyContin, fentanyl, buprenorphine. It's semantics and it's dose. Synthetically, fentanyl and OxyContin will cause more problems. Try not to prescribe them. Any prescribers. And we dabble. We always dabble. But no evidence supports dual therapy. But we will often, in difficult cases, mix. But what we won't do is put venlafaxine and duloxetine on, or tricyclics and duloxetine. There's no point. Pharmaceutical, pharmacologically, it makes no sense. It work in the same way, roughly. How do we know how they work? Do not stare at this, you'll go blind, okay? But people, wonderful Andrew Rice from Charing Cross, gets together zillions of trials, chucks almost all of them in the bin because they're flawed. He comes up with plots like this, and you can squint. I can only barely see them. Post-vetting around the different pre-gambling, and then they look how many people involved in the trial. That's the year of the paper, sorry. How many people is the size of the box, and you can see which side it tends between harmful or helpful. And you say, well, it's okay, it's generally on the helpful side, that's helpful. What is generally helpful? This paper that Andrew Rice wrote in The Lancet 2 years ago, regretfully, double the NMTs. Now, who's an expert statistician? Any expert statisticians in the audience? Good, ignore me. This is the number of patients you need to treat so one of them gets effective, and depending on what paper you read, it's either 30 or 50% effective long-term pain relief, which is 6 months. How many trips? You've got to treat 6 people. Don't forget the point, please. Gabapentin, pregabalin, capsaicin in that order. And you can see that's where the batting order comes from. If you've had a stroke or ischemic heart disease, you get put on aspirin. Agreed? You're going to give 50 people aspirin 75 milligrams to prevent one death. So is that NMT good or bad? Well, who knows? The single most helpful paper I've read in the last 5 years is by Andrew Moore, professor at Oxford. Be humble, it says. We don't know the answers. The drugs are mostly rubbish, but some may help. When you find a drug that helps, carry on. If you find the drug isn't helpful after 4 to 8 weeks, stop it. Don't carry it on. I saw a patient last Monday who was on 9 different pain-relieving medicines. 9. Come on. 4 different opioids, if you ask them. Do not know. Let's move on. Time's pressing. Has anyone here seen significant, or let's say significant CRPS? Can you see it? Brutal. Absolutely brutal. It's online. I don't know the age. It's online. The phrase that we often say to our junior orthopaedic trainees is your pain out of proportion to the original injury? Is it getting better? Have you got neuropathic phenomena? All of us can ask that question. I think you could spot that, couldn't you? Colour change, swelling, nail changes. Well, they won't be long, will they? I don't know if Fran managed to print this out for you. Fran, did you?
I did.
Thank you. So, this is a practically perfect document from the Royal College of Physicians. It's not perfect, of course, but it's so wide and so wide-ranging and so broad, it covers every specialty, including yours, physical therapists. It's in there, which I dip into with little or no evidence of knowledge. I won't pretend I know. It's there. It shows fantastic wisdom to talk about every one of the therapies. And it's sponsored by quite a few people. So it's not just the Royal College of Physicians having a go. Everyone seems to think it's not a bad piece of work. My lot, British Brain Society. I think most would say, okay, that's okay. This is somebody who broke their wrist that I had anaesthetised. Harvey Yannick had him in a splint for about 3 months and said, I need to really fix the splint, fix the fracture, there's non-union. But she's got pins and needles, temperature changes, hair changes, and grip strength is reduced. Oh, and she's a daughter of the Royal College of Anaesthetists president. We'll talk about how to do that. But this is a real world problem. Fracture that continues out of proportion with now neuropathic phenomena. Type 1, tissue. Type 2, nerve. Type 1 is significantly more common. It comes from an innocuous injury, but more commonly a fracture that has a prolonged pain history. People being people, most will heal within a normal sense of space and time, and many do. But there's a small proportion who don't. As you can see, small numbers. That's because we massively overdiagnose this. We're almost certainly diagnosing neuropathic pain rather than CRPs. I'm very happy to see people who think it's got CRP. 30% fully recover. You damage your nervous system, ladies and gentlemen, it will never fully recover. You do not have to learn these. I have to learn these. We talked about these. Think about the big red hand, colour, temperature, swelling, later changes. And the girl on the front cover has got a contraction. My first year as a consultant here, I had a patient come in like this, 18 months after she injured her arm. Nobody, well, she'd sought no treatment. The stable door has long since stopped rattling. Briefly, it is not sympathetically mediated. It is no longer pseudox atrophy. It is not RSD. It is almost certainly some degree of neuropathic pain with an inflammatory process. However, anti-inflammatories don't work very well. Prednisolone does actually. Okay? But if you've got a fracture, you give them high-dose prednisolone, they don't heal. Brilliant. Isn't medicine great? Okay, so be careful. Immunoglobulins we now give on trial basis. This is scientific speculation. There's very little evidence, if any, that patients are putting it on. That's not to think about. Peripheral sensitization, sensitizing your spinal cord and then your brain. Same as before. I know it's not the same, but helpful to think about. So this is what I asked the GPs to say. Has there been a limb injury? Is the pain out of proportion? Are there neuropathic pain phenomena? If that's the case, send them in. Orthopedic surgeons, send them in. They give us a text or an email, and they send them straight to us. We see them overbooked, just see. Will vitamin C help? Evidence is okay, single trial. So I don't know about you, but if I see a single trial, I treat it with a sense of skepticism. That's a horrible slide. All it says is physical, psychological, education, pain. It's all of it together. That's in your, I won't talk you through that. Essentially, diagnose and treat, that says. Can't really say much about this. What we do at Mason Tunbridge Wells is if the patient has got significant limb disuse and a short history, they get pamidronate, and they get a nerve block, and they get physiotherapy the same day. And they get a bit of neurotherapy as well. No, they don't get any on-site psychology. That's as best that we can do. The patients with long-term problems may need psychological support, but if the limb is disused, we send them to London, to St Thomas's, and they get a wire in their spinal cord. Very rare. Very rare. But it's those cases where the evidence amazingly exists. Now, there's surgical evidence and there's medical evidence. There's a trial with 10,000 patients to take a drug for 5 years, and there's a surgical evidence where somebody comes up with an idea and 20 minutes later everyone's doing it. Okay? There are different levels of evidence, but spinal cord stimulation is the end game. It costs about £20,000–25,000 a go. St Thomas's are our regional centre. If you have a hand like this, send them on. What this woman had was that in the pain clinic. We gave her regional anaesthetic and inserted a catheter around her brachial plexus through her axilla. I gave her IV ketamine perioperatively to block her NMDA receptor, and she got an increase in her perioperative antineuropathics. Not all of that's evidence-based, but it's pragmatic management. That is your summary. And MRI fans. That's the proper right side of this program. None of you all couldn't be pro-lab? That's bloody enormous. Sit, sit. Spinal canal. CSF. Done it properly, I think would be the phrase. Any questions? Hello.
Hello. What's the prognosis if it's left for longer than 2 weeks with the chronic? You said to always refer within 2 weeks, so I wondered how the prognosis dropped.
So we don't know what happens if you treat early, but we do know what happens if you don't treat. You get significant incapacity. So the feed is from the pain fraternity is there are a few patients who you should refer into the pain clinic as urgent. Nerve compression, cancer pain, a phone call, this is a really difficult situation, please could you help? That's perfectly legitimate and CRP. If you start therapy early, the assumption, and you're right to pick up on it, is there proof that acting early works? No. But there's proof that if you do nothing, it makes the situation worse. So one arm of that is true, the other is not yet proven. To be honest, it may be difficult to prove, but it seems to be pragmatically sensible to see that patient move quickly, because we know it's devastating. We'd love to see everybody urgently. Hello.
Hi there. That's a really interesting talk. Thank you very much.
Pleasure.
You alluded to the fact that the outcomes are not great, but the people that go to pain clinic who've got chronic pain condition and neuropathic pain condition, are the outcomes for quality of life as opposed to just pain and
Yeah.
Can you tell us about that?
There's a lovely statistic, which I'm sure. Pain is quite a neurotic, pun intended, profession, whereby we know a lot about what we do and don't do. We know that we only help about half the people who enter our door. But those that we do help get significant improvement. Okay? And it may well be functional quality of life. Pain is a poor measure. It's unidimensional. It takes into account nothing about emotion, sleep, function, medicines. Some patients will often say, my pain is the same, doctor, but I no longer take painkillers. Oh, okay, in fact, your liver will be grateful of that. So, you know, but outcome-wise, you're right. If only 30% still have symptoms, you've got to remember that half the people who won't get any benefit at all. Is it difficult to treat? Yes. Are there treatment options that may work? Yes. Let's contrast that with a nice guidance for back pain, with pretty much only 3 things are recommended. Physical therapy, the short course of anti-inflammatories, before we knew that short course of anti-inflammatories cause an increase in heart failure and heart attacks, which is Sherlock, and judicious use of injections around the median branch blocks of the back. Take time to read the guidance if you wish. It says do not about 17 times. And yes.
Is there a difference in is there a difference in the likelihood of outcome for things if it's multiple levels in the spine that are damaged? Say if you've got a patient with disc in L5 and L3, L2, rather than opposed to just one level?
The way to think about spines, in truth, and I'm sure a lot of you know this, is not to be overly focused on the results of your MR. You have to take into account that all of our MRs are abnormal. Mine is. Yours, almost unless you're under 20, 25, it will be abnormal. The question is, what is relevant when you look at the MR? Okay. If the patient is describing right-sided knee pain and left big toe pain, then it's perfectly legitimate to say that right L3-ish and the left L5 is probably relevant. But if they say, I've got a bit of pain in my butter, it isn't relevant. And you'll often see in the pain kinetics, it will say, the pain has this distribution, it is non-radicular. or it is non-concordant with the MRI scan. And it takes, I think, and I'm going to treat you like grown-ups, a higher degree of thinking to stop fixating on the details of the scan. What you're really doing is it safe? What are the patient's symptoms? And does it match the scan? Pain medicine has dined out for years on looking at something and says, that's your problem. I'll do something to it for money, let's be fair, or for kudos, or for fun. And it doesn't work. All of our spinal cord, all of our facet joints are degenerate, pretty much. But if you're walking 50 yards and your legs go numb, and you've got a massive stenosis at L4-5, it's probably the stenosis.
But if you have someone that has symptoms from 2 different levels,
Yes.
is there any papers or anything to prove that the steroids are less likely to be effective on treating 2 different levels at the same time, or steroids doesn't really matter?
No, steroids are short term.
Yeah.
Okay, you've got to think weeks to months. Okay, for even the most barred or inflamed, let's call it a hot disc, shall we? Big disc, 6 weeks, screaming in pain. Okay, you'll find no evidence for multiple level chronic. Yet you and I know that occasionally patients do really well on it. And you've got to ask yourself the question, is it working locally? Or is it the fact that if you give somebody an intramuscular injection, Demetric, they just feel better because their widespread arthritis feels better. So thinking broader, there's loads of reasons why people feel better. There's loads of reasons why that's a bad option for them. These are not easy options. If something goes wrong, you're injecting inappropriately. Good luck these days. Hello.
You all right? And you said that the chronic thing you're talking about isn't Sudex or regional pain syndrome. What for you are the key differences?
So the idea that this Sudex atrophy was the guy who commented on it, originally described it in the American Civil War, and regional sympathetic dystrophy was thought to be the changes were sympathetic mediated. So the part of your nervous system, which is the sympathetic nervous system, that has now been disproven. It is much more complex than that. So do not call it RSD. Think of it as a complex neuropathic pain phenomenon. And in many ways that's easier, isn't it? You get some peripheral stimulation, your nervous system goes mad, and now you've got this odd collection of symptoms. But the reason I did 2 of these together is the one is neuropathic pain, and the other one is much more interesting, isn't it? Let's be honest, you get motor changes, you get skin changes, you get nail changes and hair changes. Poorly understood. Don't call it RSD. Unless you're an old retired orthopedic consultant, then we forgive it. Thank you. We're going to take that as a peaceful sign.